You want to get within 24 hours a full echo to really determine the valve status, the right ventricle, their EF, and also their atrial sizes. Mostly because you want to know additionally from a long-term management strategy standpoint, are they going to be a good candidate for an AFib ablation? And honestly, if they're moderate to severely enlarged in their atria, they're probably not going to be good candidates. But you also know from that if they're in AFib now, that they're not going to be good candidates to restore a sinus rhythm, especially in the hospitalization, because maybe you're deciding on should they have an antiarrhythmic or just rate control. Anybody who has outflow tract obstruction, at least moderate, that would be a HOCM patient, they can actually have cardiac arrest from exercise. So this is the last thing they need to do. Also, patients with significant tachy or bradyarrhythmias, they need to have that addressed before they can actually have a stress test anyway. Let's fix that, right, first. And then if they have a high degree AV block, we should be considering them for pacemaker, not treadmill. Electrolyte abnormalities, especially potassium issues, need to be addressed.
And I usually like a little bit higher stroke volume than this. This stroke volume is a little bit on the low side. That's the volume that's in that ventricle. It's in the right atrium and then going into that right ventricle. So this is the amount of fluid that I actually have in that heart that heart can squeeze out. But what I am going to show you is that there are drugs that you can use. And on this patient, they wanted to start some type of vasopressor on him to give him just a little bit of a squeeze, just a scant. We don't want to let that SVR drop down so much that you're fighting a battle. You just want to keep it within range on this guy.